Good morning. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Delighted to be back with you on this warming up Friday as we get close to the freezing line here in Kansas City. Yes. We are so delighted to be here with you this morning, broadcasting live from the Dall Simons Family Studio. We've got our A-team. I have Amanda Cackler, the Director of Medical Prevention and Control. Did I say that right?
No.
What is it? Give me the right name. I never say it right, Cackler.
Infection prevention and control and quality and safety.
There you go. And quality safety.
He's medical director.
He's medical director, but you're the director.
She's my quasi boss,
Well,
and you're my boss. Yeah,
you got a lot of bosses.
The low man on the total. I know. I get voluntold to do a lot of things by my boss.
Voluntold. I like that. That's what, as it should be.
Happy Friday.
Happy Friday to everybody. We're a little slap happy, but that's okay. It's been a long week. So, Jill, let's start and see if there are reporter questions out there this morning. Before, however, I first start with Hawkeye.
Yeah, numbers, making me a little uneasy. We'll see how the weekend goes.
Starting to edge up.
We had, 28 inpatients, acute infections at one point. We have 38 acute inpatients right now.
We got down to 25 at one point.
25 then, yeah.
On the weekend or something, yeah.
10 of those in the ICU, so, and 4 of those on the vent, so 40% in the ICU or on the vent. Still 34 in that recovery period with 2 on the ventilator as well. Hays is holding steady, 16 total with 10 in that acute phase and 6 in that recovery phase.
So it is starting to edge back up there again a little bit. What do you attribute that to?
I'm just hoping it's a variability. Hopefully it's maybe a 14-day high.
Yeah.
And maybe we'll shift back down at some point soon.
Because the Kansas City numbers are still staying pretty low in the metro.
They are pretty low. And, looking on the CDC data as far as the variants go, there's still very few total number of variants that we've identified in the United States based on the CDC website. So we'll keep watching for that, looking through Next Strain as well, which is just a private lab which does genomic sequencing. And they don't have a lot of genome sequences overall, but they didn't seem to have too many of those that variant population either. So we're certainly waiting for that. It doesn't seem like the variant numbers are overwhelming. And again, the one that has been found the most is that UK B117 variant in the United States. But based on the CDC data, the numbers are still fairly low from the infections that we know of, and we know that we don't know all of the infections.
Yeah, so that'd be important information to follow. And just to say, go ahead.
I was going to say that there is, I think, 5 or 6 of our current inpatients who are in that BMT category, so they are extended in that active isolation phase for way longer than we would
So
typically
say
isolate.
that's bone marrow transplant, is that right?
Yes, yes.
Yeah. So they're still extended because?
Because of their immunocompromised status. So we have kept them in isolation for up to 30 days or longer, rather than just those 10 days in active or isolation.
Yeah, and I think we should kind of qualify that because, some of our bone marrow transplant patients are some of our most immunosuppressed patients ever that you will see. They have basically no immune system to fight any infection. So there are very good published reports about that population having active viral replication for over 115 days. So, we don't have really the ability to test that, but we kind of are watching based on that, based on their symptoms, based on also their PCR positivity.
Yeah, it's a higher volume than we typically have, so that could also be attributing to our
A little bit of a
number.
rise. Yep. So, the other interesting thing today is we look at what are the things to watch. One thing is clearly the rise of the variants, but the other thing, and we talked briefly, is this information coming out of Israel about a single dose of Pfizer vaccine bestowing 80 to 85% protection. That would be, if that holds true, and it's not truly peer-reviewed. It's been published as correspondence in Lancet, I think. If that holds true, that may shift policy. I mean, that could be kind of a game changer about what do we do with vaccination to make sure we get it into as many arms as possible. We said we want to stick with the 2-dose regimen. Pfizer 3 weeks apart, Moderna 4 weeks apart. Johnson & Johnson hopefully coming out sometime. We'll know more, I think, next week. Yeah. But that's a single-dose regimen. But if it's really true that the Pfizer vaccine can give 80 to 85% protection, and that was in looking at about 8,000 hospital workers, which tend to be a younger, healthier population, so we have to be careful. It's a little bit of it's not a truly randomized group. But if that really holds true, that may have some impact to how we view vaccine policy even here in the U.S.
Yeah, I think we do need that vaccine supply to increase, and if the data from the Johnson & Johnson vaccine proves efficacious and safe, that will increase our supply. And then we really have to get it into everybody that can get the vaccine. And even those vaccine hesitant people, there's been some talk about the messaging is different. What we have to understand from the vaccines, some people are concerned because it's not 100% efficacious. It doesn't stop 100% of the disease. But what it does do is virtually eliminate death and significantly and almost eliminate hospitalizations from those severe disease, especially in those very vulnerable populations. So
Yeah, I
that
think we
needs to be
like
the
that.
messaging.
All right, well, let's see if there are reporter questions online.
Good morning, Cody Holyoke with Channel 9.
Cody. Good,
Hey,
welcome
happy
back.
Friday.
Thank you.
Thank you. You kind of stole my thunder a little bit with this single dose. I wasn't looking at the Lancet story. I was looking at the New England Journal of Medicine one with the Canadian doctor saying, hey, look,
Yeah.
we need to get these, we need to stretch these shots out as much as possible. You talked about that a little bit, but what is the policy as it stands right now? The FDA says, look, we've approved 2 shots. That's what we're going with right now, right?
It is, and I think that's what it is for the foreseeable future.
Yeah.
Again, now Johnson & Johnson may be a single-dose regimen, and the question would then be, would the FDA be willing to change the early authorization of Pfizer and Moderna to allow a single-shot, Hawk?
Yeah, I mean, I think this continues to be a moving target and something that we can continue to debate. I don't have a problem with starting with a single dose, but if you are getting Pfizer and Moderna right now, I would still recommend, and it is recommended, that you get that second dose. Now, when is that second dose? Can that be delayed to 4, 6, 8 weeks? If you're dealing with Pfizer and 6, 8, 10, 12 weeks with Pfizer and Moderna, probably. I think you really need that second dose for those mRNA vaccines to really get optimal and maximal immunity.
I think Novavax will be the same way with its protein-based vaccine. So I think for now we're saying 2 shots is the way to go. We want to take a close look. I think the information coming out in the last 24 hours is going to spark a greater debate. And we had a pretty big debate about this 3 weeks ago or so. I think it's going to spark another debate. I think we're going to have to look really hard at this question because in the race against time, when the time is, first of all, just our own mental health and our own economic health, but also the race against the variants, I think we're going to have to take a hard look at whether or not we're better off getting 1 dose in than 2 doses in right up front, knowing we have to still get back to that second dose.
It's a great question, but right now we are actually developing the data to, further educate our answers for that.
Yep. Other questions? Or
Just a quick one about the cold stretch that we've had this week, and are you concerned about either cases going up, or is there a benefit that maybe people didn't get out of the house as much? What do you guys think?
what we know is that cold doesn't really affect the coronavirus.
Right. I would think, though, perhaps it has. I mean, I haven't really done much, and because it's been so cold out. So hopefully, folks haven't been gathering too much or exposing one another. So probably, we don't know, but probably not a contributing factor to a rise over the next couple of weeks.
Yeah, and even if it was the last 2 weeks, we really wouldn't see the rise till next week. If there's a reason to blame the rise, I'm going to blame it on post-Super Bowl depression. That's how I'm going to look at that. It goes right along with cows, Cody.
Yeah, I'm hoping, this isn't a government mandated shutdown or stay at home orders. This is more of a Mother Nature mandated. So hopefully that has allowed people to stay in their own bubbles and stay in their own houses, keeping warm.
Yeah, we'll see what happens out of Texas as a result of all this.
Yeah.
Other questions? Hearing
Not
none.
everyone can go to Cancun.
Yeah. Whoa, there we go.
All right. Okay, so we know that you have Dr. Stites kind of a hard out at 8:30.
I do.
So we have 20 minutes to rock through questions.
All right.
Before we get to the 10, however, there's 2 on here this morning that I think bear some attention. I think we need to address.
Let's do it.
This one is for Nancy. She writes, if the COVID-19 is 99.6% curable, why should I need the vaccine?
Okay.
Curable.
Yeah, let's start
Curable is
there.
a funny term, isn't it?
It's not curable. There's no cure for SARS-CoV-2 infection or COVID-19. What we kind of alluded to a little bit is that these vaccines do virtually, so far what we know and what we've seen with these past, these initial, I don't want to say strains, but initial viruses that were out there, not including B117, the UK variant, B1351, the South African variant, what have you, is that they virtually eliminate death. And they significantly reduce hospitalization and severe disease. Probably what she means is that overall we have said that 80 to 85% of the people will never have to seek medical care, and that the overall mortality rate is about 1.5 to 3%, depending on when you look at the Johns Hopkins data. But I think that's maybe what she means.
Yeah, I think what she's trying to say is it's not, I don't think it's 99.6. I think she's trying to say survivable.
Yeah.
But the problem with survival is that doesn't mean you're back to normal, right? You may have long-term neurological effects, cardiac effects, pulmonary effects. Your life may well be changed, it may be so in ways you would never want to have happen. So I think that 99.6% curable is actually not accurate. I think it's, and I'm not even sure it's accurate for survivability. But if you then said, okay, 0.6% of people are going to die, well, 1% of 300 million people is still 3 million people, right? And if you say 0.5, well, that's 1.5 million people could be dying from this disease in just the U.S. alone. I think that's an unacceptably high number when there's accessible things that you can do to prevent it. And those things are, first, medical prevention and control, right? We know how to handle the rules of infection control. They travel with you wherever you go. 2, so behavior, wearing a mask, all those things. And then 2, vaccine. And 3, drug development for treatment. And I think those things will help us arrest it. Otherwise, you're saying, well, let's just wait and people just go home, and if they die, they die. But that's a lot of people to die. And I think it's, as a physician, I would say it's an unacceptably high number when there is treatment and things we can do to prevent that.
Yeah, and I think that question also centers on the individual aspect of that. Yes, as an individual, depending on how old you are, and if you have other comorbidities such as obesity, diabetes, your chance of survival is extremely great. But when you look at the population level, we've seen what happens when 5% of the pork processing industry goes down, what that has done to inflation, the pork prices, shutting down our supply chains. We've seen what happens when healthcare systems get overwhelmed, not because people are necessarily dying, but because they are going to the hospital, taking up capacity, taking up PPE, when healthcare workers are ill, when there isn't enough vital drugs because there isn't that supply chain to get those vital drugs to those people that really need them. So it's not just about the individual health, it's about that population level health.
Okay, so Nancy, that was a great question. Thank you for that. Boyd has another question, which I thank you, Boyd, for the opportunity for us to continue to teach on this. Boyd writes, if we are so concerned about the spread of the virus, why aren't you wearing a mask? At least one, right now.
You bet. A couple of reasons. First of all, we're 6 feet apart. And second of all, the dynamics of this room, it's a negative airflow room. So what we breathe goes up, and it was designed in that way so that we could have these kind of conversations. I will tell you, as soon as I exit this room, I will have a mask on. Actually, before I exit the room, we will have a mask on. And that, because that is a great question. Nancy's question is great. That's a great question as well. And that's really why. Now, we would say, well, we've also been vaccinated and all that. But the truth is, we didn't wear masks even before we were vaccinated. But it has to do with the physical aerodynamics of this room and our distance apart. And that does make a huge difference. Our team that's in the control room right behind us doesn't have the same negative airflow. They're in masks. And the folks out here in the hallway, they're in masks, and everybody else here is in masks. It's really the negative airflow in this room and our distance apart that allow us to do that.
And I think also it's what we're doing, because we're not interacting really, moving. We're very much controlled, sitting in our chairs, facing a certain direction. When we were doing the Super Bowl show and there was food being eaten in here, we had another body in here. You were spaced even further apart because that's a more vulnerable activity, and I was in the other studio. So I think it also takes into account what activities are you doing and what's the risk of exposure related to those.
Great point. And when we got our vaccines, we put a mask on because people came right over by us.
That's right.
Okay, 2 more from here, and then we are going to rock into the other ones. Michael wants to know if we are seeing the average age for hospital admissions at KU going down. He says the case count in long-term care facilities on the Johnson County dashboard dropped to 0.
Yeah, it's really, which is great news. And I haven't looked at the age. Let us.
Yeah, but it's really hovered between 55 and 57 years old for the average.
Yeah, I mean, we have an occasional pediatric patient, but it's usually our population is between that 50s and
We'll have a specific answer
90s.
for you, though, on Monday. We'll show you the for sure date on that.
Okay, and then Betsy saw an article on CBS News, and she wants to know, they're talking about a 3rd shot may be needed to combat new coronavirus variants. What do you think?
Yeah, I actually think that's probably going to come to pass. And I think what will happen is, just like the influenza vaccine gets refigured every year based upon what the predicted changes are going to be, I think we're going to see the same thing with COVID. And I would expect that all of us are going to need a booster anyway, and that those boosters are going to look different. I think we're going to be getting vaccination for coronavirus for many, many, many years. And hopefully it's a once-a-year booster, and that's what will do it. But I think it'll be slightly different every year in terms of how they construct that.
Yeah, I think so. I think that's the prevailing line of thought right now, is that you will need some sort of booster, some sort of other vaccine. We know that Moderna or Pfizer has said with their platform, they can easily pivot and create a new thing within 6 weeks, a new vaccine. You know, what about putting one or two different spikes proteins in that nanoparticle? Is that something we can do? Novavax maybe can pivot if they get emergency use authorization or approved. They have that pre-fusion protein. Maybe they can pivot as well. We think with the AstraZeneca and the Johnson & Johnson, I think they said their ability to change or pivot will be a little bit longer than that. But I think most people do expect at least a yearly vaccine as needed.
Okay, question number 1. A study in Spain found that 80% of COVID-19 patients were vitamin D deficient, with men having greater deficiency. Will taking vitamin D help to protect against COVID-19? What does vitamin D do?
Okay.
Yeah, actually, this is a good question, because this has been going on. You know, these are other repurposed drugs or over-the-counter drugs that we take normally for our health. There was a recent study published, I forget out of where, I think it was in JAMA Open Network or JAMA Internal Medicine, but it hopefully put an end to that question. They looked at both vitamin D and zinc in combination in monotherapy with just vitamin D alone and zinc, and it had no change in outcome. So I think if you want to take zinc and vitamin D for normal health in the provided doses that are prescribed or shown on the bottle, you can do that. But as far as any prophylaxis, protection against COVID-19 or treatment when you get it, it doesn't have any effect.
You know, it's funny, I don't need as much dairy as I once did, and so my vitamin D was low, so I take my 2,000 units of vitamin D every night. And remember, it has not only bone health, it also is cardioprotective against cardiovascular risk.
And I think they did like 20,000 units of vitamin D, so very high dose.
Very high dose.
And it showed that it had no effect. So.
Yeah.
All righty then. Should you get the COVID-19 vaccine before or after a major surgery?
I would say get your vaccine as soon as you're eligible. Once you get that call, don't hesitate whether you have a scheduled surgery or not. Just get it done.
Great answer.
Yes.
What expectations should I have about the process for getting the vaccine? I hear stories of long lines. I'm 73 and I can't wait in the cold. How should I prepare?
Amanda, are we ready for that?
Yeah, I think the recommendation is when you get your appointment, this is one time in healthcare where there is no value of showing up early. Because of the logistics, we want to make sure that everyone is getting their vaccine safely, and that from a coronavirus perspective is that you're still maintaining that social distance. We're not having you gather in large groups. So that appointment time is absolutely critical. We have it down here now, and we're constantly learning about the different logistics, the availability, the number of folks that are showing up for appointments. So we're constantly changing our process, but we have it down. I had my second one on Monday, showed up, walked in, sat down, did my 12 minutes of waiting and walked right out. But I have seen whenever people show up early, it can lead to some bottlenecks. So I would say how can you prepare? Show up on time.
Yeah. I like how you were right on beat with that. That was impressive right there. That was good. Remind me of my band teacher.
If I have COVID-19 before and have antibodies, will that protect me against the new virus variants? And Michelle, she's kind of asking that today too. She said she already had COVID and she wasn't really sick and she has cardiomyopathy, but her doc said she's fine. So really, why do I need that shot?
I don't think we know the answer to this question, do you?
Correct. We don't know the answer to that question. So we have to remember that it's not all about antibodies. We know that people survive coronavirus, or people who have mild disease don't necessarily have a lot of antibodies, but they have the other type of immune response, and that's that T cell response. They have a significant T cell response. So it's not only about the antibodies. In addition, we don't know what level of antibody causes you to have the protection. We have seen cases reported about people who were infected with COVID several months ago and now have one of the new variants and have severe illness. So we don't fully understand that. To agree with you, we don't know the full answer to that. You probably still have some cross-reactivity with, I want to say, the old SARS-CoV-2 isolates and then the new variants. But to how much, we just don't know. We will probably learn more as we
It
get
was
to that.
interesting, the New England Journal of Medicine had the article yesterday that looked at both Moderna and Pfizer, and the headline in the newspapers read,
Yeah.
vaccines showed decreased effectiveness against the South African variant. It's actually not what the data says. What the data showed was there were fewer neutralizing antibodies, but there were still a lot of neutralizing antibodies. And as the authors carefully point out, we have no idea what this means for effectiveness because of all these different forms of immunity, and there's still antibodies that did work. So we don't know if it's effective or not effective, right? And I think that we probably need to make sure that our public understands that distinction.
And we do know that those vaccines do elicit a pretty good T-cell response as well.
Yeah, so it may well be they're still effective. We just don't know the data yet around the 135.
Okay, and we have a follow-up question to the surgery question. Linda wants to know, but what about the medications that they're going to give my husband when he has his surgery? Is that going to impact the efficacy of the vaccine?
Yeah, it really shouldn't, because those medications in surgery they're not immunoreactive medications. They're not going to modulate your immune system. So really that shouldn't happen. If you have a high dose of steroids or drugs that truly suppress your immune system, like you're going to go get a transplant, well, that may be true. We have actually ended up transplanting some patients who later we found out were positive at the time of surgery. We test them the day before, and we test them at the time of surgery, or a few days before. But when you get a transplant call, you don't often know. You have to get in, you get transplanted. And we've actually, I think, transplanted, 3 patients who turned out to be COVID positive, and they all 3 did well. So it's a funny world out there.
All right, question 5. If you have both doses of the vaccine and are around someone who tests positive, do you still need to isolate or quarantine? And if yes, how long?
Amanda, this is a
Okay.
great question.
This
Let's
is-
take it on.
This is sort of complicated because they have changed their guidance. Now, it's important to distinguish isolation from quarantine. So isolation means that you are positive yourself and you need to isolate from those around you. Quarantine means that you don't have the disease, but you were exposed to somebody within that close contact. So what the CDC guidance is, and I may have to tap into Dana on this one, if you are 2 weeks out after your second dose, but within the 90-day window after your second dose, and you are considered a close contact of someone who's positive, you don't have to quarantine according to the new or interim guidance.
Yeah.
However, you're still supposed to be monitoring your symptoms, and depending on that exposure, you may still be recommended to get a test based off of, because you can still get it. We have had employees and patients who have received both doses of vaccine and also turned out to be COVID positive. So
COVID positive later, even after 2 weeks.
after, yeah.
So, because that was always the question, can you still spread it? And we know you may test positive. We don't know if you can spread it yet.
Right.
But you think, well, you're positive, you may be able to. We don't know yet.
Yeah, and again, from what I understand, the folks that have had COVID positive test after their second dose of vaccine, their symptoms have been there haven't been a lot of symptoms associated with it, which is what we would expect. But as far as, is it still transmissible from someone 2 doses and positive after, we don't know that.
We don't know. We are getting better data, better clinical data, real-life data, especially out of Israel. They have said that based on their being able to dose and get their vaccines, they believe they've seen a decrease in the ability to transmit the disease. So we're still waiting for the published data on that. We hope that you can, because you have an immune response already. You have a T-cell response, an antibody response, hopefully reducing that viral replication. The quarantine issue is kind of confusing for sure, because I think what it says, and I have to go back, it is 90 days from your second dose, but you have to make sure that you are 2 weeks from that second dose. So really, it's like a 10-week period,
Right.
not even a full 12 weeks. So
The answer
it's
is
a
it
short
depends.
amount. Yeah, it's a
And the
confusing
problem with
thing.
the 10-week period is it may be prolonged. We don't know enough yet to say it is. So there you go.
All right. Can headaches and chest pain start 2 weeks after a positive test? I felt fine for days, and now I'm having symptoms.
Yeah, that can happen, right? Because you may be pretty asymptomatic, but then you can start getting some of the long-haul symptoms of the things that occur later in the course of COVID-19.
Yeah, absolutely. We know a majority of the people are going to have symptoms by, a week, 10 days. But we know that people can develop symptoms later on. But there are other things, too, that can be happening and causing those benign problems, other infections. So I think it certainly is plausible. I think you'd probably need more consultation and discussion with your primary provider for that.
I have heard of people getting urinary tract infections, fevers, blisters, diverticulitis, flare-ups, and blood clots after the second COVID-19 vaccine. Are these side effects of the shot?
What do you guys think?
Ooh,
They're not
sounds bad.
I wouldn't say that they're common side effects, and I think, again,
Yeah.
these are things that could potentially happen, I mean, based off of your what's going on with you health-wise. So again, would want to seek out probably.
Yeah, I'm going
talk
to
your
say
doctor.
no on the blood clots, probably no on the diverticulitis flare-ups, the urinary tract infection. I don't see a mechanism for that. I don't believe that was ever reported in any of the Moderna or Pfizer FDA briefs.
We've given like 25,000
Yeah.
doses or more, maybe 30,000 by now, doses of vaccine. I don't think we've seen this. I know we haven't seen this. And when you look at the national database around vaccines, this is not being reported. The problem is that people get sick after vaccination. And remember, you still have your baseline health issues, right? So if you have a history of diverticulitis, or you have a history of urinary tract infection or blood clots, or you're predisposed to blood clot development, you didn't get it just because you got the vaccine. You got it because those are diseases that occur in the community. What we know is that the vaccine does not increase that rate of occurring. So can you still have those bad things happen? Yes, you can. Is that related to the vaccine? I don't think so.
Yeah, I'll say yes, it could probably happen after the vaccine, but I don't think the vaccine is the cause.
Yes.
We do have the VAERS, which is the Vaccine Adverse Events Reporting System, which is has been around for a while, reporting adverse events from any vaccine. But we also have the vSafe, which is for the COVID-19 vaccines as well, and that's the CDC. So certainly they are collecting a lot of data, and I'm sure we'll report it if it's a significant issue.
It's been 9 days since I got my first shot, and my arm is red and swollen still where I received it. Is that normal? 9
You guys
days.
think? 9 days is a little long.
That is a little long, and I would wonder if there was anything going on prior to. Has it gotten worse? Is it about the same? Again, I think it's kind of relative to
Yeah.
what's it been like for that entire 9-day period. 9 days post-vaccine does seem long.
It's a little long. You begin to worry that, gosh, did you even have a little cellulitis? What's going on around that side?
Yeah, we know that most of the symptoms for the first shot can last 2.5 days on average, 3.5 days on the second shot. And we know that you can develop hives even a week out, but they aren't there from the day of the vaccine. So certainly we know you can have late effects, and those have been well described.
So Abby normal.
That'd be normal.
All right.
Yeah. Okay, so what show is that from?
I'm not going to date myself. I just
Come on, let's go now. You got to clear up here. You got to fess up. What's that from?
It's from a movie. I can't remember the
Young
name.
Frankenstein.
Oh, that's
Thank
it,
you
yes.
very much.
Thank you. All right.
Whose brain did you get? Abby Normals.
Yeah, I know.
I don't know what you're
It's not Friday. We are having too much fun.
Time out. You don't know what we're talking about? You have a homework
Oh,
assignment
wow.
this weekend.
I haven't seen that. I know the movie, but I haven't seen it.
Oh,
You
Young
should do
Frankenstein.
a
That's
Gene Wilder
that's a great one.
film
Mel
festival
Brooks.
binge, yeah.
Yeah.
Okay, so I
Mel
want
Brooks,
everyone
Gene
at
Wilder.
home that's watching that knows what that is to give me a big thumbs up on
Yeah.
Facebook,
Well done.
so I feel better.
It's almost as good as a Star Trek reference. Go ahead.
It is. Okay, question 9 and 10, and we only have 3 or 4 minutes if you want out
Okay,
at
let's do it.
8:30.
Well, we'll do it.
I heard it was not recommended to take Tylenol before getting the vaccine, but I heard that after I got my shot. Am I still protected, or did I mess up?
Hawkeye, I think Tylenol is okay.
Yeah, Tylenol's okay. So CDC guidance is that it is okay to take Tylenol or even NSAIDs, which are non-steroidal anti-inflammatory medications. Ibuprofen and naproxen, it's okay to take those after for symptoms such as pain and fever. They don't recommend taking it before, but even beforehand, I don't see that there's a problem. There's really no mechanism that's going to cause you to not get immunity. Again, you're probably going to take it for 8 to 24 hours after you get your vaccine. We know that immune response continues for weeks, and then even after that second dose for weeks as well. So.
Last question. I was at my mother's independent living center as they were giving out vaccine. At the end of the day, there were leftover doses, but nurses said they could not give to anyone outside of the current phases. What happens to those doses? Are they being wasted?
I know, obviously can't speak to what happened at this living center, but I know what happens here whenever we have extra doses, basically because either folks don't show up for their appointment, or we still have appointment holes to fill. We have that master list of patients who are in that criteria. So that random list that's been generated, part of the responsibility of those in the vaccine clinic is to constantly be calling folks to see if they can come in for an appointment. Like, can you come right now? A few weeks ago, we had I want to say a few doses at the end of the day because we had some holes in the schedule, and they were making phone calls late into the evening for those that were in Johnson County and were 65 and older. So we are doing everything possible not to waste any of the vaccine.
Yeah. Some of our people, and have we wasted vaccine?
We have had a couple of instances where I want to say yes, but it has been very, very few. I just asked this question the other day of our pharmacy colleagues, and it has been under 30 doses out of the grand scheme of allocations. And a lot of that has to do with the logistics of the temperature management once they are made up. And again, if you know, the cold weather and you can't get out in it and you don't make that appointment, but we do everything possible to find someone who is eligible and can get here. And we've even stayed open late to accommodate that.
Yep.
And I saw an article on TV too about, you know, county health departments doing that as well. It's easy for them because they have a list. It's easy for us because we have a list of patients. It might be a little bit more difficult for a nursing facility that doesn't have an open list of patients. So, but yeah, I mean, just as you said, we can't speak for them.
Yeah, but you can call the health department and say, hey, we have a few extra doses. Can you use them? Just
Yeah,
like you said, in
absolutely.
that coordination with health
We have
departments.
moved it around. We've tried to back up a few weeks ago. I know we were even, we would call the police department and say, hey, do you have anybody who hasn't been vaccinated? Send them up. And we do things like that in order to make sure we do. Because we treat it like diamonds and gold, man. That is such precious. And until we have a bigger supply, it's going to remain that way. By the way, I did text the master of math, David Wild, and asked him what our average age is. He said prior to 2021, the average age was 58. Since January 1 of 2021, the average age is 60. So it's interesting. So older people still getting sick more often. I don't think that should really surprise us, right? Because we
We are
haven't
not
vaccinated
older.
enough people.
You need to find a different word for that. We are not older.
Okay, good point, because I'm 61, so I'm over the average age.
60 is the new 50.
Yeah, you
Just
know,
saying.
one of my orthopedic surgeons, says, you can think that, but your joints are still 61 years old.
No argument there.
Yeah, thanks, Doug Burton, for that one. Okay, so great questions this morning. Holy cow. Monday, we have another great session coming up. Dr. Kelsey Larson is one of our outstanding breast surgical oncologists. And we had a great conversation last week. We're going to continue that about new types of radiation therapy for breast cancer patients. What's the impact of that in the COVID-19 era? So that'll be a good conversation and certainly timely and topical given what's going on out there. So thanks so much. All right, we also have a pretty cool picture coming up. A quick shout out to one of our viewers who made the Fauci Ouchie cups. I like that. Thank you for Chloe for sharing the photos of your custom-made cups that read, I got my Fauci Ouchie. Chloe writes, I heard Dr. Hawkinson make mention of the Fauci Ouchie, and so I had these custom made. That's great, Chloe. Thank you. A fun reminder to let everyone know you're protecting them and yourself through vaccination. Well done. I got my Fauci Ouchie. Final thoughts?
I think my final thoughts are kind of alluding to, you were able to just text Dr. Wild and get that data in just a second. We have a whole team of folks that work on David's team. I know David Strickland and Kevin Fitzgerald have helped us immensely have data at our fingertips to tell us what is our vaccine rate and what is our inpatient census and what are the demographics associated with those patients. So I think just a shout out to that team.
Yeah.
That is my thought today.
Thank you for calling folks out. That's perfect. And in a good way. I think that's great because we don't always get to all those folks, and they do such great work.
Yeah, it should be warm and balmy in the 30s this weekend. So if people can get out and exercise outside and
In small groups with a mask. Go ahead.
Not mixing your bubble, I was going to say, and do that and stay healthy.
You know, that is our next big challenge because next week it's going to get up to a roasty 55
Yeah.
degrees. You're going to be ready to sunbathe. But, of course, lots of sunscreen, very safely.
Sunscreen.
Actually, don't even do that. It's a terrible idea.
Dermatology.
Yeah. As the weather warms up, there is a great temptation to get back out and get back together. Just remember the rules of infection control. They have protected you all the way until this moment and on this day and every day going forward. Just think how well they work. How much influenza is there? None. How much RSV is there? None. How much COVID is there? still a lot. That just is because it's so transmissible. Follow the rules, keep yourself safe, keep your family safe, keep your loved ones safe, keep all of us safe. And remember, there's still no place like home. We'll see you on Monday.